Hello, everybody, and welcome to our session on health disparities and inequities in Medicare Advantage. My name is Gary Jacobs. I'm the Executive Director of the VillageMD Center for Public Policy, and very excited to have this discussion with you today. We have a very esteemed panel who we've all gotten to know each other a little bit in briefing for this session. And I'm going to have everybody introduce themselves after we do some quick slides to kind of set the tone and have some common language for what we're going to be talking about today. So lots of discussion in our ecosystem around health disparities and inequities generally, right? And big push by the Biden administration to focus on this issue, which I think we all know is long overdue. And we all know that COVID has kind of accelerated the discussion and has pointed out that the disparities aren't kind of there, but they really are there. So if you go to the first slide, Evan, we are using the a recent study by the Better Medicare Alliance so that we have some common definitions. And the first one was around health disparities. And from the CDC, defining health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Significant words, but as you go deeper there, persistent discrimination and prejudice in society, social, economic, environmental, and behavioral determinants of health. And by addressing social determinants of health, providers and health plans are afforded opportunities to mitigate disparities in healthcare. And I think the industry is pretty committed to that concept and that model. And when we talk about social determinants on the next slide, we kind of talk about some common definitions again. World Health Organization defining social determinants of health as conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. In other words, SDOH are the non-medical factors that influence health outcomes. Andrew's going to have additional points on this in his discussion a little bit. The CDC organizes social determinants of health into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. There's a growing recognition that SDOH have a greater influence on individuals' health and well-being than clinical care, and the COVID-19 pandemic highlighted the importance of this issue among older adults. But beyond that, I think it was pretty clear during COVID, and what remains, we're not saying that COVID went anywhere yet, but the fact that COVID has highlighted the disparities by population is a big aha moment for many provider groups, for many payer groups, and I think the country in general. So I think it's pretty significant that it opens the door to innovation and creativity afforded in value-based care. Next slide, please. When we kind of go now to the numbers, because we like to talk from numbers, right? So this was some data that Better Medicare Alliance had commissioned. And you can see in 2012 kind of where the state of things were, pretty much equal between male and female, variance of about 10 points in multiple issues. But then when we get into specifics around who was the MA population, it was different than, significantly, it was different than it is today. And when you kind of look at this mapping, the white population dominated, the Hispanic was around 10%, and the Black community was about 2.3%. Interesting, because I remember marketing to various communities in those days, and there wasn't a purposeful objective as to who we're going to go after necessarily, because as things evolve, things like risk adjustment based on chronic disease state and things like quality as a tool for outperforming others and getting paid more to do so became pretty emblematic of serving everybody in a community. And then when you move to 2017, dramatic shift, right? From 81% of the population being white to like 70%. The Hispanic population increased a little bit, but the Black community increased pretty dramatically, and multiracial and American Indian and Alaska Natives increased as well. All said that Medicare Advantage was now becoming acceptable, not only as a force for good, but it was a change agent in the way that healthcare was being defined and being delivered in the country. And we'll wrap with the last slide here on Medicare Advantage serving a higher population, higher proportion of social risk factors, which I like the one on the right when you kind of begin to look at food insecurity, kind of moving the needle on people and developing food as medicine models and programs. It was very, in the fee-for-service world, been far diminished by the Medicare Advantage world early on. And then when you look at levels of poverty, you kind of take a look at where food insecurity remains and how strong it is. And then when you kind of break down the percentage of Medicare beneficiaries by income level and take a look who's in Medicare Advantage, which is the blue chart versus the orange chart fee-for-service, kind of striking that all levels up to 400% of poverty have now become part of Medicare Advantage, and it's pretty amazing. Next slide. And Medicare is a great tool for us because it's created a lot of innovation, not out of the fee-for-service world to the value-based world. And we see that through CMMI, there's many initiatives at play that are going to open that door to drive much of the innovation to include the disparities that exist for various populations. I'd like to go to the last slide, tools in Medicare Advantage. Next one. Okay, right there. So when you look at what you're able to do in Medicare Advantage, the idea of value-based payment, giving incentives to providers to be aware of and treat these issues, I think has become quite significant. And when you look at care management as a tool, it's really factoring in now inequities and the inability to service the community because there are maybe no providers in that community, and trying to attract more people to provide care in those communities is part of the conundrum we face. The flexibility in the design of benefits and the definition of supplemental benefits going forward, what they look like. We're going to address that in our discussion. And the ability to focus on star ratings so that we have a tool to measure quality that allows us to get to the local level of what actually is happening in that community and how do we service that. My last point that I want to bring in my general conversation here is that in my organization, VillageMD, we have gone community by community. We're in 15 communities now across the country, and we're kind of expanding rapidly. We have addressed an issue around this particular issue in a recent announcement we made with Walgreens as our partner, and we have announced that we're going to move from our original 500 facilities in Walgreens to now more like 1,000 through the year 2027. So integration of clinical pharmacy with clinical primary care and all the things that are possible through that model, which gives us a lot of encouragement and enthusiasm for moving forward. But 50% of all of those facilities will also be located in underserved communities. And that was a major initiative for us on both sides of the discussions, that we can service those populations, which means that we had to retool a lot of old systems. We have to enter new markets in new ways. And it's been a very exciting journey. But having said that, my background's managed care. Been doing this for quite some time. And I want to introduce my panel and let them introduce themselves, and then we're going to have some robust discussion on this. So in my boxes, I can go to Andrew first, Ali second, and Najja third.
All right, well, thanks, Gary. I'll kick it off. So my name is Andrew Renda. I'm the Vice President of Population Health Strategy at Humana. And what that really means is I lead our social determinants of health strategy. And we have a centralized corporate team that does a lot of work directly with our members. We also have a market-based strategy where we have a footprint of 18 what we call bold goal markets, where we have embedded population health strategy leads that coordinate between our internal team and creating relationships and partnerships with community-based organizations. So that's kind of the structure of what we do. Now, I think it's important, Gary talked about some definitions of health disparities and social determinants. We've spent a lot of foundational work kind of thinking through these definitions and taxonomy of them. And for us, there are structural determinants of health, which are kind of the social and political aspects of health. There are social determinants of health, which again are the environmental and educational things that Gary mentioned. And then there are the social needs, or health-related social needs, which are the immediate individual needs that a person may have. Things like food insecurity, transportation insecurity, housing insecurity, et cetera. And that's really where a lot of our work has focused. And, we used the CMMI Accountable Health Communities Comprehensive Screener. And right before the pandemic hit, we surveyed 100,000 of our members and got responses and found that, these social needs issues are highly prevalent in our Medicare Advantage population, to the tune of, 40% have a financial insecurity, 26% are food insecure, 29% are lonely. And so, that was a wake-up call to us that these needs exist and we need to address them. And so since then, and we'll get into the details, we've developed, some analytics around how to proactively identify these needs. We've developed an innovation pipeline of solutions that we're testing and learning. And we're now to the point where we're looking to scale solutions. And Gary alluded to some of these opportunities, that we can scale some things through supplemental benefits. Some things we scale through value-based relationships with providers. In other cases, they become integrated into care management platforms. So we'll get into all those details, but we look at a variety of ways to scale and expand this work so we can impact the health of more people. So maybe I'll stop there and pass on to whoever's next.
Ali?
Great. Evan, thanks so much for having us. Excited to be here today. I'm Dr. Ali Khan. I'm a practicing general internist here on the west side of Chicago. I apologize, I was running from clinic. And I'm the executive medical director here at Oak Street Health. We are a national network of over 130 centers in 19 states today, serving the needs of complex, medically vulnerable, and really socially vulnerable seniors and other Medicare enrollees, including a large number of Medicare and Medicaid dual eligibles in communities that, quite honestly, have suffered a great deal from a structural marginalization context, right? So well before the pandemic, Oak Street, for nearly the past decade has said, we have to look at, from a CDC perspective, where is the first challenge of healthcare access, right? Particularly for primary care and pharmacy access in many communities, whether urban environments, suburban environments, exurban environments, and then say, how do we bring high quality primary care that leverages the possibilities of what Medicare Advantage and full capitation allow, to really then focus on what deeply matters, right? So from a CDC perspective, framed as built environment, economic opportunity and stability, and then really social and community context, right? So we spend, even before the pandemic, we spent a great deal of time saying, how do we really think about, what our interactions are like from a community perspective, and recognizing that if the goal ultimately is to build trust in communities that have a lot of reasons, a lot of very valid reasons to not trust American medicine, to not trust sort of our medical industrial complex, what is the work that we have to do really look like? And so for us, I think it's multimodal, right? So what does that look like in terms of interacting with patients and from a medical context, from a social context, from a behavioral health context, and from a community engagement context, in terms of really building strong and dense relationships with the community organizations that are attempting to stabilize or revitalize communities, and really providing strong, social and sociocultural bulwarks for folks to hold on to, particularly vulnerable seniors, right? Second, really, how does that look from an omni-channel perspective, right? Digital engagement is great, and we do a lot of it, but how do you marry that with the analog, especially in communities where Wi-Fi and broadband access may not be what we expect it to be in other places, right? When we dig into the issues that are prevalent in communities like I serve in West Garfield Park here in Chicago, where the life expectancy here for my patients that I've been taking care of today is 16 years different than a mile and a half down the road in downtown Chicago. So much of how we think about engagement has to be digital and analog together, oftentimes shoe leather, right? In terms of thinking about how we really close the loop towards last mile problems. And so, we'll get into this in a little while, but thinking about the last mile, think about how we've done that work longitudinally, but then particularly in the context of COVID response and the pandemic has been honestly incredibly fulfilling work, but really drives towards three things, right? Ultimately, our value proposition is that we can offer time, resources, and follow through to make the bold goals that Andrew and many others at Humana and thankfully other health plans around the country are saying, how do we make that real? And for us, that it's a logistics problem. And it's a challenge from an operations perspective, but ultimately it's a challenge to build real trust. And if we can do that, then we are leveraging Medicare Advantage to its fullest to really say health equity can become real as opposed to just a concept.
Thank you, Ali. That's great. Najja, very different perspective now we move to what's happening in communities around the country.
Yes, good morning. Good morning, Gary. Once again, my name is Najja, or I'm the president and CEO of the Philadelphia Corporation for Aging. We are one of 52 area agencies on aging in the state of Pennsylvania and more than 600 across the country. I will say that we do follow the same path as many of our AAA partners, brothers and sisters across the nation, where we generally follow that first path of assessing and assisting consumers that want to stay connected to the community. That would be a host of programs like senior centers, health and wellness programs, volunteer opportunities, senior employment opportunities, making sure that they have access to transportation. That would be that first path. The second path is assisting older adults that need additional supports to stay safe in their community. And that's where our care managers go into the homes and into the community and complete comprehensive assessments to really tailor care plans to meet their individual and specific needs. We would pair them with services like home care, home delivered meals. We talked about nutrition, adult day services, medical equipment and supplies, home modifications, things like that. And then that last path we generally follow is advocacy and protection. And that would be programs like the Ombudsman program for addressing complaints for individuals that receive long-term care services or legal supports and services. And then, of course, our Older Adult Protective Services Unit to do our part to ensure people live free from abuse, neglect, financial exploitation, and abandonment. Here at PCA, we have more than 30 programs, and we generally serve more than 140,000 older adults annually. A lot of what we do, as I mentioned, does have strong synergies with the social determinants of health that we were talking about a little earlier. And we have a very, very strong focus on diversity, of course, here in Philadelphia. With almost 1.6 million residents in Philadelphia, We have more than 311,000 older adults, and our city being extremely diverse, about 58% of that population is from a diverse community. And of course, 12% identifies as limited English proficient. So I'll stop there and hand back to you, Gary. Thank you.
Thank you. Najja, how about if I begin there? And so you had a lot of things happening in Philadelphia this year. You had floods, you had horrific weather, you've had COVID. Can you talk about, from your perspective, the work that provider organizations like Ali's and payer organizations like Andrew's, how have you been interacting with them, and have they reached out to you, or have you reached out to them? Could you kind of give us a little sample of what the real world is like in terms of that representation of communities that are lacking core services, so that we don't have what Ali described as a 16-year differential in life expectancy? What are your thoughts when somebody like me brings this up to you?
Yes, I would say that we've certainly done a good job over the years of making connections with our collaborative partners and other stakeholders in the city of Philadelphia. I could say nationwide that roughly 50% of the area agencies on aging across the nation are currently working with integrated care partners, including managed care organizations. We're looking to strengthen our relationships, of course, with our accountable care organizations. I would say that to me, it's the partnerships and the collaboration that really help the rubber meet the road. If it were not for partnerships and collaboration on our end, there's no way we'd be able to do all that we've done over the last 20 months with the challenges that we've seen. For example, related to COVID, we've had an opportunity to partner with the Philadelphia Health Department to assist with individuals that were not able to get to a vaccination site. They were sending staff out from the fire department to do vaccinations in the home. Also locally, we've had an opportunity to work and partner with organizations like the Black Doctors COVID Consortium, where they're doing a really, really excellent job of trying to meet the needs in the community for those individuals that aren't able to get out of their homes and have a close local feel to their community. They're doing things like that. We've also had to do things like pivoting a lot of what we do, and that's relying on partnerships, looking at our senior centers that traditionally provided a congregate meal program had to pivot to grab and go meals. And for those individuals that were waiting for being assessed for traditional home delivery meal program, if it were not for partnerships of individuals helping us get some of those meals delivered, then we wouldn't have had as great of a reach as we've had. One thing I can say is I know that the AAAs across the nation, not just here in the state of Pennsylvania, are eager to continue those discussions on how we continue to partner with our federally qualified health centers, our accountable care organizations, our managed care organizations, to show our value proposition as well.
Thank you, Najja. That's great. And I would like everybody to feel free to ask any questions in the chat box. I'll be looking at them, and feel free to address them. So, Andrew, something that I think about a lot from a payer perspective, Blue Cross of Massachusetts recently, maybe it's not so recent, but I think over the year has announced that there is an additional payment available now that is equity tied and focused on bringing more provision of services in communities that are lacking core services. So they're creating incentives in the payer world to actually move providers to stand up and, rise to the occasion, if you will. Do you look through that lens? Is that an anomaly, or do you think that's the beginning of a payer trend to attract providers like Ali and ourselves into communities that we haven't been before?
Yeah, let me try to answer that. I think first off, there's an increasing awareness amongst all parties, be they providers, payers, that there are health disparities, that there are highly prevalent social determinants, health-related social needs that exist. And once we all stipulate that there's a problem, then it comes down to how do we solve that problem? And typically there's not a single way to solve it, there are multiple ways. And so, within our Medicare Advantage, products, we look at a variety of different ways we can do that. Now, in some cases, we can begin to address social needs through benefit design. So we have special supplemental benefits for the chronically ill. That allows us, people who have chronic conditions and a need for care management, we can begin to address social needs when they are root causes of those exacerbated chronic conditions. We also have benefits, demonstration benefits out of CMMI, like value-based insurance design, which allows us to start to address social needs for people with low-income subsidies or lower socioeconomic status. So benefits are kind of one way that we look at doing that. But we also look at other ways, and value-based care certainly is one. Now, the incentives are coming around, but for now, we kicked off a pilot last year with some of our value-based providers where we're beginning to incentivize primary care doctors to address social needs. Now, what that really means is we pay an incentive to do a social needs screener, a validated screening instrument to document whether someone, had a social need using, ICD-10 codes, and then to make a referral to a community-based organization. So, those are kind of two ways that we look at doing that. And yes, we need to get creative with, where incentives are available and sort of how that works. But a lot of that, even before the incentives come in place, I think we still have some work to do to all stipulate that social needs are health related. And that's why I think, going back to what I said at the very beginning, definitions are really important. We can talk about structural determinants of health and social determinants of health and social needs, but it's really important that we start to define those as health-related social needs. And that's a term that CMMI actually coined as part of their Accountable Health Communities work. And we've adopted that because I think, prior to Chronic Care Act in 2018, food, for example, was explicitly excluded as being a value-added benefit. And since Chronic Care Act, and since we've had some of these newer opportunities, now we can begin to address these social needs in certain circumstances. So, I think we have some work to do there. And once we all agree that they are health related, that they are highly prevalent, that they are, influencing people's health and their health outcomes, then we look for all sorts of possibilities of how we can intervene and address those root causes so people can achieve their best health outcomes.
That's great. And Ali, you want to tie this together a little bit?
Yeah, I think this is fun for me to think about only in the context of thinking about the connective tissue between sort of what Najja presents, right, is like obviously multi-sector partnerships are advancing health, but in ones in which I think we think about these in like some of the traditional actors, right? FQHCs, obviously area agency being a big leader, other large systems, sort of community-based organizations, versus then where Andrew's coming from is saying like, okay, like we are trying to build a drumbeat for the recognition of structural and social determinants of health. How do we bring that in as in a real recognition of how this impacts health outcomes and overall, patient level activation and viability? And how do we then start to move people towards trying to address those issues, even from a referral context? I think what is interesting here is that the last couple of years in particular have really shown us from a pandemic perspective that incentives can do a lot here, right? And really unlocking what we think are really novel public-private partnerships to do this kind of work and at scale. And I think, so our experience from an Oak Street perspective has been, look, we serve almost, of our 130 clinics, almost all of them are in high social vulnerability indice communities as defined by the CDC and by, city, local and, state levels Department of Public Health, right? In a lot of those places, we are the only built environment that exists from a healthcare perspective because most health systems and a lot of private practices may not be there. We may have, one outpost in FQHC who is attempting to try to figure out how do we address the incredible challenges faced from a pandemic perspective or every day, even pre-pandemic, while also trying to make this work from a fee-for-service perspective and see patients, on that treadmill. And so for us, when you have full incentive alignment, as we do from the kind of full risk capitation that Medicare Advantage allows and dual eligible plans allow, that enables us to go to community partners like Najja's and say, as we've done in Chicago and Philadelphia and Detroit and many other communities around the country, and say, listen, let's do this differently, right? Let's be the private sector partner that can offer not just funding, right, and from a traditional context, but really operational and logistics excellence, the actual physical plant in the communities where we saw some of the highest disparities in terms of number of COVID deaths, in terms of the highest concentration of essential workers, but even seniors who were caring for grandparents or grandchildren and other family members who could not isolate safely, who did not have food access reliably, who could not access dry goods. And how do we work together with, networks of CBOs in Chicago over 55 to say, how are we building out real capacity from COVID testing, right? In the communities that need it at the hours that they want it, not just 8 to 5 because it's convenient for me to do it, but because they're working second shift, third shift, and they need, evening and weekend hours, right? How do we go in and open that kind of access from a vaccine perspective to communities that, particularly for seniors in high SPI communities that need transportation, I can call a Lyft, but it's much easier if they can walk, right? And they can walk safely. So, in that same context for us, partnering in that way for the first time really deeply with, institutions like the Chicago Department of Public Health, right? The Illinois Department of Public Health, Philadelphia DPH, other places, we were able to vaccinate over, 250,000 people, the majority of which are seniors, and to be clear, the majority of whom were not our patients, right? In alongside other 1A and 1B healthcare workers who were shut out of the system because the system gave vaccines to big health systems, but they forget, the home healthcare workers that are working in the communities in North Philadelphia and West Philadelphia that are serving the seniors that Najja thinks about, right? Or thinking about the seniors in Louisville that, Andrew sees every day as he's, head of the office, right? The opportunity that emerges in when we get the incentive alignment right in Medicare Advantage is enormous from the kind of connective tissue that we can build to create real public-private partnerships, connecting the incredible intent of health plan partners like Humana and the operational discipline and the community context of partners like Najja's, and then using sort of the value-based delivery systems like us as the conduit to make these actually happen and happen at scale in real time, right? I think the story for us has been just seeing that opportunity and being able to really drive public-private value has been really eye-opening. And I'm hopeful that we can continue to think about more of this as we face, not only the next several pandemics, but really the depth of work that emerges in really ameliorating structural violence in the communities that we all serve.
So Ali, I think a lot of what you're saying gets to the issue of fee-for-service as a payment methodology fails us in addressing this issue. And the longer that we have relied on that system, Andrew's not going to say, well, here's a code for X, whatever the inequity might be. And we respond to that code by providing a service. No, we get paid, blah, 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 blah. But in a value-based world of, let's say, capitation, we know that we get a predictable revenue stream based on a population we're managing, and we can bring these resources to bear. Agree?
Yeah, Andrew has a hard job, right? He's got to incentivize health systems and clinicians of all sorts and sizes and all sorts of arrangements to do this work that we all know is so critically important. For us in the value-based world, right, our job is to know that 98% of our patients are facing some sort of structural determinant of health. 60% of them are facing at least one or more real social determinants. And then we have to ameliorate those through a lot of different programming. And the way that we do that reliably and effectively is by partnering with Najja and with others to make that real, right? So it's easy for me to sit here and say this on some level, but because obviously when we think about the large breadth of practice styles and incentives in American medicine, it's harder. But when you can get it right, and I think this year has shown us how we've been able to really address, to have the incentive alignment, to have all the reasons to go deep on this and really think about what what meaningful, not temporizing amelioration of social risk factors look like, it can be pretty powerful.
Andrew, let's get it a little deeper into some of the reasons why the definitions you talked about earlier were so important to Humana and to managed care from a payer standpoint. So you address things like social needs, environmental needs, and what are you thinking about as where, if we're looking down the road a couple of years, what does this all look like from that view? I have a particular view in what I think CMS and CMMI should be thinking about or could be thinking about on this front. And I'm sure all of us may have that. I get to talk to them about this every now and then. What are you seeing from the big picture today? And where do you see it going 5 years down the road, maybe?
Yeah, it's a huge question. I mean, I think, yes, I kind of define that structural determinants, social determinants, and social needs. I think, by necessity, we have to start with the health-related social needs because they are immediate, they are individual. And, my other panelists sort of talked about the idea of aligning incentives between different stakeholders, be they payer, provider, community-based organization. I think that's absolutely true. The other side of that, though, is thinking about return on investment. In order to justify bigger investments in addressing social needs, we have to have the structures in place to measure impact. So what's the impact to health? What's the payback in terms of financial payback and reductions in acute utilization? And so, I think by necessity, we've got to start with social needs because they are individual needs. They are urgent and immediate. They can be addressed. We can treat them like clinical quality gaps in care, which they are. And if someone's food insecure, it's going to exacerbate their diabetes. It's going to put them in the hospital. And so you address that food insecurity, then there's a reasonable expectation that you're going to see a short to midterm payback on that then justifies, scaling and doing that on a bigger scale. So I think we have to start there. I think that, there's a lot of work to be done even to figure that piece out because you do have to align incentives. You have to agree on terminology. You've got to create data interoperability and all of those things. And just think of logistical barriers that we even face when we're trying to work with community-based organizations. Traditionally, many of them are small scale and they rely on philanthropy, on grant funding and things like that. When we want to go contract with them like we would any other vendor, suddenly we realize that, they don't have $10 million in, data security insurance. They don't have the infrastructure to redline a contract. There's these logistical things that we don't even think about that we've got to figure that piece out. So there's a lot to be done even to figure that initial piece out. We've got to align the incentives. We've got to get all the stakeholders on board. We've got to study with the same rigor that we would a clinical intervention, these social determinant interventions. Then we can start thinking about scaling through those various mechanisms that I spoke about. Now, once we figure all that out, which is a ton to figure out, then I think we can go even further upstream. Then we can start thinking about social determinants of health, thinking about the educational system, thinking about the environment that people live in. That's a whole different thing. And then even further up from there with the structural determinants of health, you've got to think about, policy advocacy. You've got to think about the social environment that we live in. And that gets into inequities and disparities and, racial biases and all these really deep-seated things that are really complicated to figure out. So you asked me 3 to 5 years. I would love to get to the point where we are addressing social determinants and structural determinants, but I feel like we still have a ton of work to do, even in the immediate health-related social needs. So that's largely where our focus is now, just again, by necessity. I think we've made a tremendous amount of progress, but we have a lot left to do. And so, that's where we're focused now from a data standpoint, from an interoperability standpoint, from a partnership standpoint, an innovation standpoint. And it's hard. It's hard because I think the further upstream you go in intervention, the longer downstream the sort of traditional ROI comes. And that's what we really need to get to justify these bigger investments that create the sustainability and the scalability of this kind of work.
Andrew, do you typically collect data on issues like this? Do you ask members these type of questions to determine, where they are economically, where, race issues? Is that a beginning, or is that already you're okay with that or in that?
Yeah, no, I mean, we started doing that certainly with social determinants or social needs probably about 3 years ago. We've been scaling up our screening since then. So just for example, that first year, we maybe did 1,000 screenings through a handful of pilots. Last year, we did over 6.2 million social determinant screenings, on our membership. So that represents about 20% of our 4 million Medicare Advantage members. And we plan to scale up from there. Now, a lot of that came from direct screening, direct to member screening, where we use that Accountable Health Communities comprehensive screening instrument. So I mentioned that 100,000 responses that we received right before the pandemic. That since has become kind of a baseline in terms of prevalence of individual social need domains within our membership. Since then, we have resurveyed several times through the pandemic to see how those prevalence have changed. And it shouldn't be a surprise, but many of them got worse. And we'll continue to do that. But I think also we've got to incorporate social needs screening into our clinical operating models and our value-based care relationships and our EHRs with providers, so that we're screening really at the point of care and at the sort of opportune time for intervention. So it needs to be part of a care manager, be they telephonic or in home or inside a clinic, is assessing, how's your diabetes going? Are you taking your medication? They're also asking, do you have transportation to your next appointment? Do you have food in your fridge at home? Do you have a stable housing environment? Like, those types of questions are really key, and we need to integrate them into all the assessments that we do. And so that's where I think we have some work to do, and we're making some progress there, but have some more work to be done. Because ideally, everyone would be screened all the time, but we're not quite. And I'll say one other thing around that is, as we've created this data ecosystem around social determinants, we've had to build a taxonomy, frankly, around this data, where at the top, the gold standard is a known screener, a validated screening instrument, or an ICD-10 code that says someone is food insecure or not, right? But if we don't have that, then we think about derived data sets, where we begin to get more into advanced analytics. We have predictive models now for different social need domains. We have a social risk index that will say that there's some propensity for someone having one of these issues, so that we can proactively reach out and hopefully intervene. If we're not able to do that, if we don't have enough data even to do the derived types of analytics, then we have to look at sort of our third tier, which is inferred. And those are geospatial data sets that we import from outside of our company. We think about Robert Wood Johnson County Health Rankings. We think about CDC 500 cities, think about census data, all these sort of external geospatial data sets, where we can say, if you live in this certain area, there again is some propensity that you suffer from the social need. So, getting back to your original point, ideally we would survey everyone with legitimate validated screening instruments. Until we get there, we've got to rely on advanced analytics and geospatial data sets, that give us a sense of what's happening for the people that we're serving and the communities that we're serving, so that we can go out and intervene and try to close those gaps.
Thank you, Andrew. We have a couple of questions, but Najja, I want to kind of go to you and put your advocacy hat on for a second. And when you hear us talk about these issues, what comes to mind in regard to the people you're serving every day and you're dealing with every day, and through their various mechanisms to access you, boards, committees, infrastructure, being in the communities? Is the private sector and the government sector stepping up enough, or are we too early on and we need to step it up much quicker? Kind of give us a sense of the world from where you sit on this.
Sure. I think we're certainly becoming more aligned, and we're seeing greater synergies there over the years. I would certainly say that for me, it resonates closely when I think of what Dr. Khan said when he mentioned this is an opportunity for us. This is an opportunity for us to do things differently. And combining that with Dr. Renda, and when he mentioned, making sure that we're all using the same language and we have the same dialogue and the same definitions. I think those areas are key. So when I think of work, and even in the diverse space, I think of, Philadelphia was once the epicenter for COVID in the state of Pennsylvania, and now the contraction rate has been one of the lowest in the state. Does that mean we're at a perfect place now? Absolutely not. I think that we certainly have more strides to go. As we look at our Asian population, it's about 79% fully vaccinated. The Hispanic population is about 60% vaccinated. Our white population is about 59%, and our African American population is about 49%. So we certainly have strides there, and that's why I think strengthening those public-private partnerships will really help us thinking of non-traditional ways that we can continue to support people collectively in the community. I think of lessons learned just even over COVID, and I think of how, as we talk about moving the needle, thinking of continue to things and advocate for eliminating barriers to delays in program enrollment, and making sure that we're looking at non-traditional ways and partnerships that will strengthen our supports as we're looking at food insecurity at the AAAs, and looking at housing programs and looking at home modifications. I think those are opportunities for stronger collaboration. Looking at, as Dr. Renda and Dr. Connor, constantly looking at data and metrics and innovation. The community-based organizations are starting to have those conversations on a regular basis as well, is what helps best to drive our outcomes. And as we look at output, moving from output-based to outcomes, to really have a stronger focus on the return on investment. And then I mentioned earlier, just making sure that we bring all stakeholders to the table related to collaboration. This is really an opportunity for, managed care organizations, Medicare Advantage plans, accountable care organizations, community-based organizations to work even stronger than they've worked together in the past. I think of recently, my two youngest were at the dinner table and they were having a conversation, about learning some language in school. My son's now studying Latin a little bit. My youngest daughter is now studying Spanish, and my wife and I are looking at each other like, we can't help them. But you know what? Bottom line is, how do we come together and have common definitions, common language, so we can all talk the same language? One of your slides earlier spoke to star ratings, so that way we all see the same language, the same definition, and working towards the same goals as we're looking at validating the impact that we have to the community.
Thank you so much. So we do have a question that involves family caregivers, and there's a value statement about the need for recognition that family caregivers are helping members with conditions like dementia who are disproportionately Black and Hispanic. These members drive medical spend. Why does the discussion of SDOH not encompass family caregivers? I do not think that it doesn't. I think we haven't had time to talk about that today, but it's a big issue, and it's a $5 billion burden in society today, right? It's a big number. And anybody want to address it all? Or I hate to say it, but we're almost at wrap-up time. And I kind of like, go ahead.
I can start there. I think without a doubt, family caregivers is a very big portion of that conversation. Community-based organizations and the area agencies on aging across the program, we have programs like the Caregiver Support Program that not only focuses on the loved one who's caring for an older adult, but there's a component to the program that also assists with older adults who are caring for their grandchildren. We know that in Philadelphia, about 30% of our residents live in multi-generational homes, and so we in our research estimated that about 41,000 grandparents live with their grandchildren, and we know that there are other grandparents that are caring for their grandchildren. So that's a big component of some of the assessments as we're assessing consumer needs. We want to make sure that the family and formal supports are there for that assessment process. And that's a big component of how we infuse and looking at the holistic care that we're going to support them to really shape around the supporting the caregiver.
Okay. I think we'd love to see a national benefit from obviously from a caregiving standpoint. That's another conversation for another day. I think that what Najja really lays out, right, is like we can't really wait for that kind of policy when we think about how do we support vulnerable seniors and other Medicare enrollees in the community, right? So for us, this really becomes, again, how do you pivot to handling last mile challenges at scale that help those caregivers and those patients alike not worry alone, right? So knowing that they have, a secure, steady access to rides, not by trying to call their transportation benefit, but they know that, an Oak Street van will come get them and take them home, and at times take them to the pharmacy or, help them get to another medical appointment is enormous, right? For those grandparents who are caring for grandkids, the fact that it makes no difference for us to buy the car seats so they can come sit in that van, right? And then move forward. And then, that each of our centers has 1,000 to 1,500 square feet of community space where if they want to be in that appointment, they can be. If the caregiver doesn't want to be in an appointment, needs a break, they can sit there, have a cup of coffee, get internet access, which may not be something that they have reliable access to in their homes. Sit in a warm environment or a cool environment, depending on the day, and just think about this, right? In the pandemic, supporting caregivers by really saying, okay, nobody's coming in a clinic by and large. Let's use those vans to deliver food and dry goods on a weekly basis so that caregivers and patients alike are supported. And that we think about, because we know the ecosystem, right? Because we are paid to know those details, that we know this, hey, these guys need supplies for 6, not supplies for 1, right? It is that level of sort of differentiation, that level of, sort of crossing the T's and dotting the I's that makes a difference in helping caregivers not worry alone. And even something that, as simple as helping them access the benefits that Andrew and others at Humana are giving on respite care, right? That they don't even know they have or have no idea how to access, just so they can have some wellness themselves in this uncompensated work. We know we need to be doing better in terms of how we support caregiving as a nation, but in the interim, we can't afford to wait. And so how do we leverage the range of options that we have to stabilize and uplift that caregiving community?
I think you also raised another great point, and Andrew, we're gonna go to wrap up, okay? But for you, from Ali's question, is kind of like a caregiver benefit, even if offered at open enrollment, many times loses value unless the primary care doc and the agent and the health plan are reminding the member when the need is there, they have this benefit, right? I've seen that in a lot of scenarios where there might be a benefit there, but they don't really remember it or they don't know it. Maybe they even signed up because of that benefit, they thought. But until the care manager or their primary care doc raises it at some level, they may forget they even have it and they don't know what to do. Right?
Yeah, I think to me there's a communication opportunity there, and there's a technology opportunity, because I think yes, it's common that there's many benefits that get baked into a health plan that someone may select, and then after they get selected, then they may or may not be aware or remember that they're eligible for something. So it's on us to some extent to communicate that those things are available. The challenge becomes, they may not need it now, but they may need a caregiving or any other kind of benefit 3 months or 6 months or 9 months from there. And so it's a question of how do we become aware, or how do we act in an opportunistic way? And that's where it gets to the technology piece. So if we have a CRM, for example, that a customer service person, a care manager, an EHR, a physician using an EHR, any point where that person, it's a person at the end of the day. They may be a patient, they may be a member of ours, but they're a person, that they're interacting with the system, that when a need is identified, that a service is connected to address that need. That's really what we want to do. Someone comes in, we're asking the right questions about clinical needs, care navigation, social needs, and when that thing is flagged, that issue is flagged, we say, okay, well, let me quickly look up. You're eligible for these benefits, these programs, these services. Which one is the best fit for your need right now? And we make that immediate connection. So that's where technology can play a really important role.
I think that's great information and great insight into what's happening from the payer world. how about if we do a, 30-second wrap up? Najja, we'll start with you, and we're so happy you were able to join us today. Thanks.
Thank you, Gary, and want to thank also Dr. Khan, Dr. Renda. It was a pleasure to be here with everybody today. Once again, the area agencies on aging across the country like to consider ourselves the front door for long-term services and supports. Any questions or concerns that people have regarding supports and services to older adults, reach out to your local AAA. We're always a resource here for you. And always, once again, looking for those collaborative partnerships, those relationships with organizations like Dr. Khan's and Dr. Renda's.
Thank you. Ali, 30 seconds. Go.
Yeah, I suspect Najja and I have a lot to talk about in terms of our work in Philadelphia, so more to come there. I think this is just a great example, right, of where the last couple of years have prompted, obviously, a deep introspection led by groups like Andrew's around bringing rigor and consistency to the recognition of what structural marginalization and structural racism looks like in America, right? And the opportunity that we have here now from a Medicare Advantage perspective to leverage the tools within this payment model to then create the kind of, really novel sort of cross-sector partnerships that can drive actual change on the ground and do that with like legitimacy and with real consistency over the long term. That's what's amazing here, right? So I'm, separately trying to scheme on how I can get as much of Andrew's data as possible that he just leveraged. So it's high quality, it's reliable, and it shows what's the best out there, right? From an intervention skill set. And then how do we all partner together to implement that using the Oak Street network as a real framing tool and as that army is really exciting.
That's great. Thank you, Ali. And Andrew, last word?
Yeah, I'll say it really quick. I think health disparities exist, social needs exist. They're highly prevalent. Humana is committed to addressing them for sure. And bigger picture, I feel like Medicare Advantage is very well positioned to address these types of needs through everything that we've talked about, be it benefits, be it services, be it value-based payment innovation. Medicare Advantage is really well positioned to address those needs over time.
Well, I want to thank you all very much on behalf of the Better Medicare Alliance. This is, I think, we're in the infancy of this discussion, and there's so much we really need to understand about each other and walk past each other every day. And, we can't take anything for granted from COVID. We realize every moment of our life is a unique and special, beautiful moment. And caring for each other is part of that. And we can go on and on, right? But the mission in front of all of us is helping people receive high-end care wherever they can and be consistent in helping them address it, right? And very, very thankful that all of you were able to join us today. I think this has been a great conversation and look forward to next year, and maybe we could do it again. Thank you.
Thank you.
Thank you.